Hey guys, welcome to EMT class. Would certainly like to see you face to face, but obviously that's going to take a while for us to do. So I'll do the best that I can to get this information across to you. My name is Larry Martin. I'm a retired firefighter paramedic from the Mesquite Fire Department, and then I worked 2 years in the Carrollton Fire Department as their EMS trainer. I've been teaching for 27 years now, so hopefully you can get quite a bit out of this presentation. All right, today we're going to talk about respiratory emergencies. You will see quite a few respiratory emergency calls during your career, probably more so now that the COVID thing's going on and flu season coming up in the winter, so you'll probably get more than your fair share of respiratory emergencies. So it's very important to make sure you understand everything, the pathophysiology, the anatomy, the treatment thereof, and so forth. So again, just pay attention, and I think we'll get you through this okay. Now, you should have had patient assessment by this point, excuse me, so you should have had some of the preface of at least how to assess someone with a respiratory emergency. So just kind of review this a little bit. What do they look like? A lot of people that are having difficulty breathing, they'll do something called tripod breathing. As soon as you walk in the room, you'll see them sitting straight up as possible. They'll have their arms straight out, but their hands are on their knees, and they're trying to get their airway as in line as they possibly can to where they can move more air. This is something that you can see from across the room. As soon as you walk into the room and you see somebody tripoding, then you can pretty much guarantee that they're having some type of difficulty breathing problem, excuse me. They may have poor skin color. People that are hypoxic or their oxygen levels are low tend to turn blue or cyanotic. Sometimes they'll be pale. Look at their work of breathing. As far as looking at it, there may be some nasal flaring. The nostrils tend to flare more with children than they do with adults. Does it look like they're fighting to breathe? Do you see muscles above their clavicles, like in their neck area, being used? You see that quite a bit with people that have chronic obstructive pulmonary disease like emphysema or bronchitis. Do you smell anything? If someone has inhaled or ingested either one cyanide, they may smell like bitter almonds. So there may be alcohol on their breath. Yes, alcohol can cause difficulty breathing because you tend to not do real smart things when you're under the influence of alcohol. Again, a tripod position is where they're sitting straight up with their hands on their knees, trying to get their position, or trying to get their airway as open as they possibly can. A sniffing position is just where, like, you're standing there talking to someone and a smell comes by and you raise your head just a little bit to smell whatever is wafting by you. That's a sniffing position. Again, that's a way for them to get their airway more in line. Circulation, again, is it blue or cyanotic? That's typically a sign that their oxygen levels are low. Guys, it's real easy to check their oxygen levels. You have a pulse oximeter that you can stick on their finger. It looks like a clothespin. It takes just about 5 to 10 seconds to calibrate, and then you should be able to get the amount of oxygen that's saturating their red blood cells in a very, very quick amount of time. Also, is there any other life threats? Some of the worst difficulty breathings that I have ever seen have actually been cardiac in nature. They go into congestive heart failure due to a heart attack, and that typically can cause them to go into respiratory distress. Okay, so here's medical terminology for the day, for this chapter. This is the word dyspnea. The word DYS means difficulty, and PNEA means breathing. Don't tell anybody that is complaining of difficulty breathing. Don't try to tell them that they're not having difficulty breathing because their pulse oximeter is 95%. If they think they're having difficulty breathing, then go ahead and accept that as truthful and treat thereof. This is a very common chief complaint. They also may be complaining of chest tightness, and tightness can be several things. You can have someone having an asthma attack and they can have a tight chest. You can have someone who's having a heart attack, they can have a tight chest. You can have someone who is having an issue with the emphysema that they live with every single day. However, it's worse today. They may have some chest tightness. People who are having anxiety attacks or panic attacks can also have some chest tightness as well. So you have to do a good physical exam on your patients to figure out what is the cause of this chest tightness. Anxiety levels, not that this can't happen to adults, but we see this a lot more often in kids. Something upsets them, they have a panic attack or anxiety attack. That's usually pretty easy to figure out. They typically have some numbness and tingling in their fingers and toes. They may have some numbness and tingling around their mouth as well. And, if they just tell you that their boyfriend broke up with them, then, and all of a sudden they started having difficulty breathing, then probably it's going to be an anxiety attack. They also can be restless. Anytime you get to the point that you're having difficulty breathing, you get very excited or restless because you think you're about to take your last breath and you're not able to catch your breath. So the more restless they are, probably the more into this difficulty breathing complaint that they are. Is this something that's chronic? People with COPD or chronic obstructive pulmonary disease, that's either emphysema or bronchitis. They live with that 24 hours a day, 7 days a week. Typically, when they call us is when they can't handle it anymore. These people are usually on oxygen 24 hours a day. When that nasal cannula at 2 liters a minute is not quite cutting the mustard for them, then they'll call us, and we need to treat what we find. You also can have an acute onset. If you've got someone that was exposed to some type of noxious environment, carbon monoxide, you guys, you're in the fire service, you're going to be exposed to a lot of stuff that you're not going to want to be exposed to. Asthma typically is also an acute onset. Asthma is not considered a chronic disease. You can have asthma and nobody really ever knows you have asthma until you actually have an asthma attack. So try to figure out, is it chronic or is it acute? Okay, so this lady, she's tripoding. You can see that she has her hands on her knees. She's trying to sit straight up, trying to get her airway as open as she possibly can. Noisy breathing. If you hear gargling, gargling is typically in the upper airway, and the upper airway is considered anything above the larynx or the voice box. Gargling is indicative of some type of fluid. So suction is going to be your best friend at that point to try to suction the whatever material is causing that gurgling out. Snoring is upper airway as well. Snoring is typically caused by the tongue, and it's a very easy fix. Do a head tilt, chin lift. If there's no C-spine precautions that need to be taken, if there are C-spine precautions, then you can do a jaw thrust. Wheezing is typically a lower airway issue. Not all wheezing is asthma. A lot of wheezing is asthma, but not everything that causes wheezing is associated with asthma. You can have people with pulmonary edema that can have wheezing. People with COPD can have wheezing. You can have a foreign body obstruction that can cause wheezing. So wheezing is typically heard when a patient exhales. Whenever you inhale, that's an active process that your muscles are being used. Your diaphragm, your intercostal muscles are being used to draw that air in, but exhalation is a passive process. So there's really no muscles that are being used when you exhale. I think the best example of that is if you have a patient who is unconscious, pulseless, and apneic, and you take your back valve mask and you blow a breath of air into them with your back valve mask, that dead person can exhale on his own. So now you can hear wheezing on exhalation, but typically, again, it's usually heard on inhalation. If they're not able to speak in full sentences, like they're only able to say 2 words before they have to take another breath, and we call that 2-word dyspnea. 3 words, obviously 3-word dyspnea, and so forth. They may be using their accessory muscles, like their intercostal muscles, the muscles in between the ribs, or they may be using the muscles above their clavicles to help draw that air in. A lot of the pulse rate is pretty much dependent upon this event. Are they typically, when they first go into a difficulty breathing event, the pulse rate is increased, just if nothing else because of a sympathetic response, that fight or flight response that, hey, I can't breathe anymore, so I've got a big dump of epinephrine that's going to cause my heart rate to increase, and so forth. As this starts to progress and they start to deteriorate and they become even more hypoxic, then most likely that pulse rate is going to start to decrease. Okay, so do they have adequate breathing? Do they have inadequate breathing, or are they not breathing at all? Obviously, the easiest of all of these to assess is the ones that are not breathing. Again, sometimes you'll actually lay your eyes on a patient and it looks like they're adequately breathing, even though they are complaining of difficulty breathing. So use all your senses, use all your techniques that you use to assess a patient to try to figure out, are they having difficulty breathing, or are they having adequate or inadequate breathing? Excuse me. Okay, so if it's adequate, does the chest rise and fall equally? Every time they take a breath in, does the chest rise equally on both sides? Or is there one side that is coming up higher than the other, or not coming up at all? What's their skin color? It should be pink. In dark-skinned people, that can be somewhat difficult to see. So what you can do is you can pull their eyelid down, look at their eyelids. You can look at their mucous membranes, and if the mucous membranes are pink, then that's typically a good sign. Does the air pass through the nose and the mouth easily? Again, if you're not hearing any kind of gurgling or snoring or anything associated with upper airway issues, then they're probably having adequate breathing. Any abnormal noises in the lungs, if you don't hear wheezing, if you don't hear what are called crackles, which is indicative of fluid in the lungs, then they probably have adequate breathing. I know it's difficult when you have gloves on to feel the air coming in and out of a patient's nose and mouth, so that can be somewhat difficult to figure out. But a lot of times you can put a non-rebreather mask on them, and every time they exhale, the non-rebreather mask will fog up, or you'll see condensation in it. And again, that's a pretty good sign that they have that they're moving at least air out adequately. Make sure you listen to breath sounds. The back is much better to listen to breath sounds than the anterior portion is. We typically listen to the anterior portion a lot of times because we're lazy. Most of the patients that we pick up are going to either be sitting up in a chair, they're going to be laying on their back. I'm sure that when you go to the doctor for any type of issue and he or she checks your lung sounds, I'm sure that they listen to your back when they're listening for lung sounds. You can listen on the anterior portion. That's okay, but again, you're probably not going to hear the sounds as well as if you did it on their back. Some of the sounds that you may hear in the lungs are wheezing. We've already talked about that. I think about as lengthy as I can. Rails or crackles. This is from pulmonary edema. Probably the most common type of pulmonary edema you're going to see is someone who has congestive heart failure. We'll save that for the cardiovascular lecture, which will be next. Rhonchi is in the bronchi. So it is in the larger airways. Typically the rails are in the alveoli, which is the very distal end of your respiratory system. And fluid is always going to be heavier than air. So if they're sitting up, you're going to start hearing the rails in the lower portions of the lungs, and then as it starts to progress, then it's going to migrate up into the upper portion of the lungs. But rhonchi is in the bronchi, so that's a lot higher up in the airway than what your alveoli are. It's going to sound very coarse and rattling, whereas your rails is going to sound more wet than what the rhonchi will. Stridor typically is an upper airway issue. You typically don't hear it in the lungs themselves. Stridor is indicative of some type of partial upper airway obstruction. It could be from medical issues, especially in kids, like croup or epiglottitis. It could be from a partial foreign body obstruction in the upper airway. It could be from smoke inhalation. So stridor is typically heard on inhalation. And again, it's going to be above the larynx where you typically hear stridor. Anybody that you pull out of a house fire, you need to make sure that you do a good job of assessing them, because the smoke inhalation that they can have can certainly cause stridor, and it can get to the point that the airway will completely close if it goes on long enough. Excuse me. So adults, typically somewhere between 12 and 20 breaths per minute is what's normal rate for them. Kids 15 to 30, and infants 25 to 50. The rhythm should be regular. The breath sound should be present and equal. There should be very minimal effort to breathe. If you ever hear someone, like when you guys start doing your skills assessment, your psychomotor assessment and exams and so forth, if someone tells you that your invisible patient, that their breathing catches your attention, pay attention to that. They're telling you something's wrong with their breathing. Breathing that is adequate should not get your attention whatsoever. And also, does the chest expand equally and adequately? All right, so we have got to figure out, do we need to provide artificial ventilation with oxygen, or do we just need to give them oxygen, or do we not need to do anything at all? Okay, this seems to be one of the issues that that a lot of people seem to have issues with. Is the, when do we ventilate? When do we give oxygen? When do we not give oxygen? So let me see if I can clarify this right from the very beginning. Let me revert back to this slide for just a second. Let's just talk about adults for right now. So you have an adult, they're sitting there watching TV, they're probably going to be breathing between 12 and 20 times a minute. All right. This is you. You're sitting there at the station watching TV, and now a full box comes in, and on your way there, you're putting your gear on, and all of a sudden they call a second even before you check out. I would venture to guess that as soon as you step off that engine with that 100 pounds of gear that you have, and the excitement that you have of getting a second alarm fire, that your breathing rate is going to go above 20 breaths per minute. All right, you go in there and you put the fire out single-handedly, and you come out. I can almost bet you your respiratory rate is going to be above 20 breaths per minute, but there's a reason that it's above 20 times per minute. You're excited. You're exerting yourself. So really nothing needs to be done with you at this point, as long as you're okay with, the breathing of, 30 to 40 times a minute, because that would be acceptable. I would also think that when you go to bed at night, you're probably breathing less than 12 times per minute. And if you're breathing 8 to 10 times per minute, there's no sleep apnea associated with this, then you probably don't need oxygen, nor do you need ventilation. So here's kind of two extremes of when you may have someone who is above the rate that's acceptable. However, there's really nothing that you need to do to try to either bring that rate up or bring that rate down. When we get to endocrine emergencies, we'll talk about people with diabetes. Folks with diabetes, when their blood sugar gets really high, they tend to have a respiratory pattern called Kussmaul's. They may be breathing 40 times a minute very deeply. That's exactly what they need to do. They've got a lot of acid built up in their blood, and they're trying to get rid of that acid by breathing that deeply and that quickly. When they do that, they're helping themselves. If you try to slow that breathing down with a back valve mask, then again, it's kind of contraindicated in these folks. You're not doing them any favors by trying to slow that breathing down. So now, on the other hand, let's go down here to this people who are inadequately breathing. So again, outside the range, guys, look and see, is there a reason that it is outside the range? If there's a good reason that it's outside the range, then we probably don't need to assist that ventilation. Is that rhythm regular or irregular? Did he have abnormal breath sounds, or did he have increased work of breathing? Is their chest expansion shallow? Now, if their chest expansion is shallow, common sense would tell you oxygen by itself is not going to get that expansion to go any deeper. However, you can certainly make that expansion greater if you use a bag valve mask and try to positively ventilate this patient with a bag valve mask. If they're unable to speak in period, or they can't speak in full sentences, then again, you have to look, excuse me, you have to look and see, is this just an oxygenation problem, or is this an oxygenation and a ventilation problem, both? So if this person, if their chest is rising and falling adequately with every breath that they take, you hear decent breath sounds, yet you put them on a pulse oximeter and their pulse oximeter is 92%, they really don't need to have their ventilations assisted. They just need to have oxygen put on them. However, if there's inadequate rise and fall of the chest, their breathing is shallow, they're not breathing at all, then certainly you would need to get your bag valve mask out and assist the ventilations. What's their skin look like? Is it pale? Is it cyanotic? And again, cyanosis is a pretty late sign of hypoxia. And is their skin cool and clammy? Feels just like a fish. Now with pediatrics, this is the leading killer in kids is respiratory issues. One thing, especially with kids, that you need to really, really pay attention to is their heart rate is pretty much solely dependent upon what their respiratory status is. If they have a poor respiratory status, then they're probably going to have a low heart rate to go along with that. So usually if they have a low heart rate that is caused by a respiratory issue, whenever you take care of the respiratory issue, that typically will take care of the slow heart rate as well. Kids tend to deteriorate quite a bit quicker than the adults do, so it's imperative that you get to these kids and you treat them as aggressively as you can to try to keep them from deteriorating quickly. Okay, so you look at this kid right here and you got to think, yeah, this kid's probably breathing okay. He's happy, he's throwing his arms up, so the kid really doesn't look distressed whatsoever. But kids tend to, again, open their nostrils up and flare them out to get more air in through their nose. Kids are obligatory nose breathers up until about 9 months to 12 months. They don't really realize they can breathe through their mouth yet. So they're obligatory nose breathers. So you got to think that if you got a 6-month-old, their immune system's not very well developed, they've got a snotty nose, they may have some difficulty breathing just strictly because of the phlegm that is in their nostrils. Seesaw breathing is horrible. This is where the chest and the abdomen are opposing each other. So when they inhale, the chest is rising, whereas the abdomen is sinking, and then the opposite happens whenever they exhale. They're not able to move very much air if they're seesaw breathing. Grunting is a way for them to prolong their expiratory or exhalatory stage. Your old COPD patients, especially your emphysema patients, they do something called pursed lip breathing. It's almost like they pucker their lips up to blow out a candle. They're doing that to prolong their respiratory phase. Well, kids don't understand they can do that, so they grunt instead. Do they have any, yes, I sneezed into my sleeve. Do they have any retractions, the intercostals or the muscles in between your ribs? Do they have any suprasternal? You have a notch right above your sternum. That's called the suprasternal notch. If you see any excess retractions there, that's pretty indicative of inadequate breathing. And then are they using the muscles above their clavicles in their neck area? Are they using those? Again, that's probably a pretty good sign that they're having some difficulty breathing. Pediatric patients with bradycardia during a respiratory emergency, they're either near respiratory and or cardiac arrest at that point. So again, it's imperative that you treat these pediatrics with low heart rates, treat them aggressively. Again, most likely your best friend in this situation is going to be your back valve mask with oxygen. All right, so let's take a history on these folks. As far as the signs and symptoms, let's say that you get there and here's a old emphysema guy. You know he's an emphysema guy because you walk into the house, you see an oxygen bottle as soon as you walk in the front door, you see 50 feet of tubing snake through the house, and there's a guy on the other end with a nasal cannula and he's smoking a cigarette through his stoma. He probably called you because his emphysema has gotten worse and he can't really take care of it himself today. So go ahead and get an initial pulse oximeter reading on him to see what you're working with, get a baseline, and then that will help you decide what type of oxygen therapy do you need to do with this patient. Do I need to do a non-rebreather, which can deliver up to 98 to 100%, or do I need to go with a nasal cannula with a higher concentration than what he's got running right now? Get your sample history, which is your past history. Get your OPQRST. That is your present history. And if they're having such difficulty that they can't answer your questions themselves, then you may have to ask family or bystanders to help you out with the answering of these questions. Also, guys, look around the room. If you see inhalers all over the place, or if you see nebulizers, or if you see oxygen bottles, then you probably have someone who has got a respiratory issue already. Okay, so we want to get knowledge, again, with our ample history to try to figure out what the patient's condition is. Again, this is going to be what he already has, not necessarily what's going on today, which that would be your present history, but what kind of history has he had prior to today that will kind of give us some clues about what we're dealing with. Make sure that you get all the medications. As you're getting medications from any patient, regardless of what their complaint is, it's not a bad idea to ask them what they're taking that medication for. Some of you will be better than others at understanding home medications and what they're for and why people take them. But let's say you're the smartest guy in the department that understands these drugs, and you understand that a patient is taking a beta blocker and you learn that as something that people take for high blood pressure. It certainly can be taken for high blood pressure, but also can be taken for people with migraine headaches. So always ask your patients, why are you taking this medication? Okay, so here are some causes of people having difficulty breathing. They may have an upper or a lower airway infection. This could be bacterial, this could be viral. So always a good idea to wear a mask yourself to try to prevent the spread of any upper or lower airway infection. They may have acute pulmonary edema. Again, this is typically caused by someone who has congestive heart failure that they have at some point in their life had a heart attack. COPD is either emphysema or chronic bronchitis. They can have asthma. They can have anaphylaxis, which is a reaction to some antigen that's entered into their body. Basically, it's an allergic reaction. They can have a spontaneous pneumothorax. Here's a tall 16-year-old, 6'5", 180-pound kid watching TV, and all of a sudden he has some difficulty breathing. He may have actually popped a hole in one of his lungs, and that's going to cause him to have some difficulty breathing. There could be an obstruction of the airway. This could be not only upper but lower as well. They could have a pulmonary embolism. Most pulmonary embolisms are actually caused by a blood clot that has moved from one part of the body up to the lungs and has settled in the pulmonary artery. However, it can be caused by fat, it can be caused by air. So there are other things that can cause pulmonary embolisms. They can have hyperventilation syndrome. This goes back to the anxiety and the panic attacks. That's typically what you're going to see when these folks are having an anxiety attack. These are pretty easy to figure out as well, not only about the numbness and tingling in the fingers and the toes, but also their oxygen saturations are typically 100%. They're not hypoxic whatsoever. They're just breathing too fast. Environmental or industrial exposures, and you guys have picked the prime example of being exposed to all types of Okay, so the chronic conditions are going to be the COPD. Asthma is not considered a part of COPD. The asthma, some kids have asthma, and then as they grow older, they actually outgrow asthma. So the two chronic issues that we have are going to be the emphysema and the chronic bronchitis. Now, some of you may have had bronchitis in the past. It tends to hit some people, but when it becomes chronic, I believe that actually the definition is you've had bronchitis 2 times in a year for 3 successive years, then that is what they consider chronic bronchitis. With kids are subject to lower respiratory diseases and infections. There may be some type of swelling in the respiratory passages that we don't necessarily see these kinds of things with adults. Don't put anything in their mouth to look. Don't try to take a tongue blade or a tongue depressor, or even not necessarily even looking in their mouth. That could cause, especially if they have a condition called epiglottitis, that could actually cause that epiglottis to swell to the point that it completely occludes their airway. All right, so let's talk about some of these specific types of issues. COPD, again, is emphysema, chronic bronchitis. You may have heard something called black lung. That's typically when you think about the coal miners in Virginia, they're exposed to that daily, and so they get a condition called black lung. Usually this is your older patients. They have this 24 hours a day, 7 days a week. I'm sure you've seen these out in public. They either have an oxygen cylinder on a wheels that are running along behind them, that they're dragging behind them, or now they're making little backpacks that they can wear that give them supplemental oxygen. Causes are going to be cigarette smoking is one of the biggest ones. And when you look at the elderly population that's out there now, they lived through the 40s, 50s, and 60s. Everybody smoked back then. If you've ever seen any footage from the JFK assassination, and you look at all the news people that were covering that, every single one of them smoked except Walter Cronkite. They were smoking on TV. I Love Lucy. They all smoked. So smoking used to be posh. Hopefully with the education that we have now, hopefully we can see some decrease in cigarette smoking. So hopefully later on in your career, you're going to see less people with emphysema bronchitis than at the beginning of your career. Now, with vaping, it's so new that we really are not sure yet about the effects of vaping, and is that a huge cause for COPD, just like the smoking was. So we'll just have to wait on that. Chemical exposures and pollution. So if you live in a highly populated area like Dallas or LA or New York, then obviously the pollution is going to be worse than if you live out in the country. So with chronic bronchitis, you have the inflammation of the bronchiole lining. This is going to produce a lot of mucus. So when these guys are coughing, they typically have a productive cough, meaning that when they cough, something is going to come up. Usually it's going to be kind of a yellowish, very thick consistency, almost like chewing gum. And that's their big issue, is they have that mucus buildup in their bronchi, so they're having big issues with getting the oxygen from their mouth and nose down to their alveoli. They may have either damaged or destructed cilia, which that's the little hair-like protrusions inside your bronchi that help get rid of the mucus. So, excuse me, those can actually be destroyed or damaged. We typically call, let me go back here just a second. We typically call these guys blue bloaters because they're typically overweight. There's where the bloater comes from. And they typically are blue because of the fact that they can't get the oxygen past that excessive mucus down into the alveoli to make their skin turn pink like it should be. Now, with the emphysema, I don't know what you guys will see, but I saw far more emphysema patients than I saw chronic bronchitis patients. The emphysema patients, the same things that cause someone to get bronchitis will be the same things that cause people to get emphysema. Again, cigarette smoking is number one here. The alveolar walls break down. Now, these people are going to look very, very different than what your bronchitis people are going to look like. We call these people pink puffers. Puffer means that they take a very short inhalation phase, but they purse-lip breathe to try to prolong that expiratory phase. So their expiratory phase is going to be much longer than what their inspiratory phase is going to be. The reason that they're pink is because they have more red blood cells. They have a condition called polycythemia, which is excessive red blood cells. So the more red blood cells you have, the more oxygen carrying capacity that you have. So that's why these folks typically are pink. Also, these people will have what's called a barrel-chested appearance. Their chest looks expanded whether they're inhaling or whether they're exhaling. These people are usually very thin, just like your bronchitis people are usually overweight. These people are usually very thin. You will probably see huge neck muscles from them using their supraclavicular muscles to help them breathe. Now, this is not going to be like a football player that's, neck is as big around as the head. You're just going to see a very thin neck, yet you're going to see some muscles that have been overused that is causing those muscles to try to hypertrophy or enlarge. So the treatment for both of these is going to be the same. So if you should happen to misdiagnose, does the guy have bronchitis or emphysema? That's okay as far as the treatment goes because the treatment's going to be the same. All right, so again, these folks are probably going to be on oxygen already. Obviously, they called you because they can't handle this anymore. So I doubt very seriously that just increasing the flow rate on the cannula is going to do them a whole lot of good. So you're probably going to have to think about getting your non-rebreather out and getting your non-rebreather up to 15 liters a minute and giving them a higher concentration of oxygen than what they can get with the nasal cannula. All right, asthma typically occurs in younger people. I mean, you can have it as an older person, but usually this is more of a younger population disease that has asthma. You can have asthma, and you could be sitting right in front of me, and I have no idea you have asthma until you have a asthma attack. If you're sitting right in front of me and you got emphysema, then I probably know you have emphysema because that's something that is chronic, whereas this is just episodic. Whenever you have an asthma attack, that's when they're treating your asthma. So if you have asthma, you're not going around taking hits off your puffer or taking nebulized treatments around the clock. It's only when you're having an attack that you are using your inhalers or you're using your nebulizers. So you see all the causes here. In my career, out of all of these, the ones that I saw most commonly cause this is when you have very large differences in temperature during a single day. So it's 85 degrees in the afternoon, and then that night it drops down to in the 40s or 30s, and then the next day the same thing. So when you have those extreme temperature changes, that's when I saw quite a few asthma attacks. If you look right here, well, let's look right here first. This is a normal bronchiole. You kind of get a 1-2 punch with asthma. You see how this is swollen or inflamed. Well, so you see the diameter is quite a bit smaller than what this normal one is. Well, to add to that, you've also got mucus that's helping fill up that smaller bronchiole already, and so that even causes more restriction of air, making it from your from your mouth and nose down to your lungs. Okay, so these folks don't have any problems getting air in because that's an active process. These folks have problems getting air out. So that's where you're going to most likely hear the wheezing is when they're trying to exhale the air that's trapped in the chest. Now, we talked earlier about the emphysema folks having a barrel chest, so it's barrel 24/7. These people, if they have an asthma attack that's progressing, they have air that's trapped in their lungs. And so during that asthma attack, they may have a barrel chest just because they can't get that air out. But they don't have one 24/7 like your emphysema patients do. Okay, so what should I expect to hear with lung sounds? Let me tell you this, guys. Anytime that you see that definition, if someone ever asks you what's the definition of wheezing, the thing you need to look for in that definition is the word musical. All right, I've never seen a textbook out there that didn't say it was a high-pitched musical sound. So that's what you're looking for when you're looking at wheezing. Again, with most of your diseases, you typically hear wheezing on exhalation, not on inspiration, but it can be heard on both. All right, so this is due to some type of bronchoconstriction. It also can be caused from, maybe it's not bronchoconstricting itself, maybe it's just bronchoconstricting because there's mucus plugs in there that is causing it to be restricted. Or, as in the case of asthma, you can have both, where it's actually getting smaller and it's filling up with mucus. Wheezing is typically not associated with a foreign body obstruction. That's typically going to be more stridor instead of wheezing. Just remember, guys, again, wheezing is not all asthma. It can be other things like we talked about with the emphysema or the bronchitis. All right, the rails or crackles, these are bubbly popping sounds, typically when they inhale. So you've got some type of fluid that is filling the alveoli and the small bronchioles. Pulmonary edema is probably the most common thing that you're going to see. Again, most commonly secondary to congestive heart failure, meaning if they had a heart attack at some point in their life, their left ventricle is no longer capable of pumping blood to the top of the head or the bottom of the toe, so it tends to back up into the lungs, and that's where you get the fluid in the lungs. However, you may pull someone out of a house fire and they have smoke inhalation. Smoke inhalation can also cause pulmonary edema, which will result in crackles as well. Pneumonia can also cause crackles. Typically with pneumonia, not always, but typically they're going to be running a fever. With pneumonia, they typically don't run fevers at all with pulmonary edema. If you have hair long enough, you can twirl your hair in between your thumb and your forefinger next to your ear, and that kind of mimics what crackle sounds like. Again, rhonchi is very coarse, rattling. Typically, sometimes you can even hear it without your stethoscope. You can hear it from across the room. Remember, rhonchi is in the bronchi. This is typically caused by some type of thick secretions of mucus in the larger lower airway. Bronchitis can be caused from emphysema. They can aspirate something that's made it down into the lower airway and into one of the bronchi. They can have pneumonia, or they can have congestive heart failure. All right, stridor is in the upper airway. Typically, this is caused by a foreign body obstruction, or again, with kids, they can have a condition called croup or epiglottitis. With any age group, you can have someone who's having an allergic reaction, smoke inhalation, airway burns. Those can cause stridor. You typically hear stridor when they inhale. So that's a huge difference between stridor and wheezing. Stridor is typically heard on inhalation. Wheezing is typically heard on exhalation. Okay, so what do I need to do for these folks? Well, you probably should never be using one of these while you're on duty. If you want to keep one of these in your personal vehicle or keep one at home, great. But they do make these now. You see a valve on there that this medic or EMT is blowing into. That is a one-way valve. So whenever you blow through that valve and they exhale, it comes out the side. It doesn't come out through your mouth. However, again, with the COVID thing going on and other stuff with respiratory issues, you're probably better off not using this, but if this is all you got, that's all you got. Excuse me. You can hook these up to oxygen. That will give them a higher concentration than what you're just blowing through with your mouth. The bag valve mask that we see here, you should, saw this. You should have seen this during your CPR part, but typically, whenever we inhale, we have about a 500 cc or milliliter amount of air coming into our lungs. When you squeeze that bag halfway down, that's about 500 milliliters or 500 cc. So that's a typical breath. It's just a half a squeeze of that bag valve mask. Make sure you use that good EC clamp technique like we're seeing here. Make sure you have a good seal. Remember, when you don't have this hooked up to oxygen, you're delivering about 21% oxygen. However, when you have it hooked up to oxygen, if you have a adequate seal around the patient's mouth and nose, then you should be able to give 100% oxygen. Okay, so if we need to open the airway, then we can do a jaw thrust. If we feel that they have a neck injury, we can do a head tilt, chin lift if we need to, if there is no C-spine precautions that need to be taken. If they need the Heimlich maneuver. Now remember, if someone is grasping their throat, that's the universal sign that they are choking. Ask them one question and one question only. Ask them, are you choking? If they say yes, okay, you don't need to do anything because they are moving air, so that's only a partial obstruction. You just need to encourage them to cough. Don't pat them on the back. Don't give them sips of water. Just encourage them to cough. But if they nod their head and they've got the deer in the headlight look, you need to make sure that you do the Heimlich maneuver. You do it until one of two things happens. Either it comes up or they pass out. Once they pass out, then you need to start chest compressions. Do we need to put an oral airway or a nasal airway in this patient? Okay. If the tongue is an issue with occluding the airway, if they have a gag reflex, we cannot use an oral airway, but we can use a nasal airway. If they do not have an intact gag reflex, then we can use an oral airway. If they need suctioning, then get your suction unit out and suction the upper airway. And then if you need to cause some positive pressure ventilation with either your mouth mask or your bag valve mask, then proceed with that. So when you are providing artificial ventilation, we give them enough air to get their chest to rise. So look for visible chest rise and fall. With the adults, you need to do one breath every 5 to 6 seconds, or that's going to be 10 to 12 per minute. With the pediatric population, including infants, you're going to give one breath every 3 to 5 seconds, which is 12 to 20 per minute. So if you're in a situation and you ever forget, I don't really remember these ranges, just remember with adults and pediatrics both, you've got the common denominator here at 12. So if you do 12 a minute, you're getting a high end on the adults. You're still within that range on the low end with the pediatric patients. Okay, so if we are doing some artificial ventilation, let's look and see if what we're doing is actually working. Does the pulse rate return to normal? Their skin color was once blue, now it starts to pink up. Their pulse oximeter was 85%. We start using our bag valve mask with oxygen. Now the pulse oximeter comes up to 98%. If we have them hooked up to capnography, if their capnography was above 45, and now it's between 35 and 45 millimeters of mercury where we'd like it to be, then again, those are all good signs that we are successful with our artificial ventilation. Okay, so supplemental oxygen can be three different ways that EMTs can do. One is a non-rebreather, one is a nasal cannula, and the other one is what is called CPAP, which is continuous positive airway pressure. All right. We'll talk about CPAP here in a little bit, but so we have got to, again, realize, what do we need on these patients? If the patient's sats are in the low 90s, high 80s, if they have good tidal volume, their chest is rising and falling okay, probably a non-rebreather because their O2 sats are that low. But, if their sats are 94 and we want to get it up above 95, then probably a nasal cannula will be enough for that patient. With CPAP, we typically don't use CPAP unless they have pulmonary edema. It's a device that I'm not sure if you guys have been through fire school yet, but if you have, then you'll know what I'm talking about. If not, then this will be a heads up on it. When you put your air packs on, you have a bypass valve that you can turn on, and it's flowing continuous air with pressure into you. Okay, so that's kind of what CPAP is on these patients. Okay, so positioning, again, they're most likely going to want to sit straight up. If you have a patient who has got pulmonary edema secondary to a heart attack, if you try to lay them down, they're probably going to fight you to their last breath to not let you lay them down, because that's going to make their breathing worse. All right, now y'all's pulse oximeter is actually integrated in your EKG monitor. So there'll be this, you won't see this at all. Again, this is going to just plug into the EKG monitor over here. Put that on their finger. You notice that you have the wiring on top of the finger. That's the way it should be. And you just put this on the finger. You want to go ahead and get this at room air if you possibly can. To see what a baseline is. However, if you walk in and, again, they're just really struggling to breathe, go ahead and do your oxygen therapy and or your bag valve mask if needed before you put the pulse oximeter on. All right, so normal reading, somewhere between 95 and 99% is what we're looking for. If it's below 95%, then this is going to indicate some type of hypoxia or low oxygen levels in their body. 91 to 94% is considered mild hypoxia. Probably those folks are going to be okay with just some type of supplemental oxygen unless they're having like real shallow breathing and you need to get your bag valve mask out. Most likely the 86 to 90%, which is moderate, or the 85 or less, which is severe, probably these folks they most likely are going to need a bag valve mask more likely than they would have than the mild hypoxia that would probably just need oxygen. So let me try to explain at some point in this class, you'll probably hear the difference between or hear people talk about respiratory distress and respiratory failure. Again, we said that respiratory arrest is the easiest for us to see. If they're not breathing, then they're not breathing. That's pretty much a no-brainer for us. But sometimes it can be difficult to determine if someone is in respiratory distress or are they in respiratory failure. Respiratory distress is typically just an oxygenation problem. What that means is they're getting the air in and out. They have no problem whatsoever moving air in and out of their lungs. They have good tidal volume, or the amount of air that's breathed in or out during a single breath. Their chest is rising and falling adequately. Then they most likely are just in respiratory distress, and oxygen is going to be the treatment that you would start on that patient. However, with respiratory failure is not only a oxygenation problem, but it's also a ventilation problem as well. So these folks not only have low O2 sats, but they also are going to have problems with getting the air in and out. So they may have poor chest rise and fall. They may have shallow breathing. They may have an obstruction that's causing that. So most likely your bag valve mask is going to have to be used with someone who is in respiratory failure. Okay, so there's two medication delivery devices that can be administered by an EMT. We have a small volume nebulizer, and then we have a metered dose inhaler, also known as an MDI. So here's your MDI. All right. Now these patients have to have these prescribed to them for you to be able to assist them in using them. All right. So usually one of the more common ones that you see are albuterol. Kids are starting to get a medication called Xopenex that they're starting to use, but it really doesn't matter to us what the name of that drug is, as long as we look at it and it's prescribed to that patient, then we can assist them in using their inhaler. Now, you go to a junior high and kids like to share things. So you got Johnny who's got asthma, and you got Susie that has asthma, and Susie didn't bring her inhaler today, but Johnny's got his, so Johnny lets Susie use his inhaler. That's not hers, so you should not be giving a patient someone else's medication. So you see that the way she's got this, whenever she pushes down on the canister, she needs to be taking a very large breath and try to get as much of that medication into her lungs as she can. With kids, you may see actually a spacer between the inhaler and the patient's mouth. The reason that they will have a spacer is they may not be able to have enough tidal volume to get the entire amount of medication in that one breath. So the medication will hang out in that spacer until they can take another breath, and then they can get the rest of that dose of that medication in that next breath. All right. You typically don't see adults that have spacers on their metered dose inhalers. So the medication name, typically the generic one is going to be albuterol or metaproterenol or isoethirene. Trade names are going to be Ventolin, Proventil. Both of those are albuterol. Alupin's the metaproterenol, and the Bronchosol is the isoethirene. Again, in my career, I saw albuterol probably 100 times more than I saw any of the other medications. Now, again, albuterol in either the generic form or the trade form like you see here. So what these do is they just bronchodilate. I mean, that's their sole purpose, is to get into the bronchial tracheal tree and bronchodilate that bronchoconstriction that's going on, and that allows the patient to get more air down through that tracheal bronchial tree into the alveoli. All right, so when would you consider calling in and asking? Well, first off, again, let's look back here. All right, you see how she's able to take her medication. So I've asked students in the past, when would you ever need to assist a patient with taking their inhaler? I mean, it's pretty simple. They put it in their mouth, they squeeze the canister, and they take a breath in. I don't really know how you can do things any better than them. So I've had some students that go, well, what if they're unconscious? Well, you know what? You're not going to give this to someone who's unconscious. They have to be conscious and be able to take a breath in on command for you to be able to do a metered dose inhaler. So unless they just have not been trained properly in how to use an inhaler, I doubt very seriously that you would be called upon to assist them in using a ventilator, or I'm sorry, an inhaler. All right, so if they're having signs and symptoms of difficulty breathing, it has to be prescribed by physician. It has to have their prescription on there. And then you're going to have to call in, because this is not your medication. You're going to have to call into your medical direction and say, hey, I've got a 18-year-old female who's having an asthma attack. She has a metered dose inhaler of albuterol. She's unable to take it herself, but she is able to take a breath on command. I have looked at the albuterol. It is hers. It is prescribed by her physician. It's 2.5, or it's whatever the dose is. I'd like permission to assist her in taking her inhaler, and they're probably going to grant you permission to do that. All right. Now, there's two things that you really need to watch out for. These are most likely going to happen. Okay. First off, their heart rate is probably going to increase. That's typical. Probably also they may get jittery. That's typical as well. So pay attention to both of those. If you see them, and that's just one of the side effects of these type of medications, but don't be too alarmed if you see that happen. All right, so when do we not use this on a patient? If they're not able to use it, all right? If it's not prescribed to them, if you don't get permission from your medical direction, or if they have used their maximum doses, and you're just going to have to find out from the patient how many they're supposed to take. That's not something that is universal, that every patient can only take up to 3. So you're just going to have to ask the patient or the patient's family members what is their maximum dose that they're supposed to be taking. Okay, so the prescribed inhaler, again, it's a metered dose inhaler, and so it will have on there typically how many puffs to take. It typically does not have a dose per se. It just typically says, 1 to 2 puffs or whatever as needed. So this is what's called a beta agonist. You have beta 2 receptor sites, and just remember you got 2 lungs, so you got beta 2. You got 1 heart, there's beta 1. So an agonist, that means is going to help a patient, or it's going to cause a reaction, and that's what we want. What the beta agonist effect is it bronchodilates, all right? This is going to reduce the resistance in the airway, and this is going to cause them to be able to move more air in and out. So again, watch out for those tremors, the nervousness, the increased pulse rate. Guys, that's going to happen, okay? I can almost bet my bottom dollar that you're going to see that with every single patient that you give a prescribed inhaler to. So make sure you check your vital signs before and after you do the inhaler. Make sure that you're doing a focused reassessment on the respiratory management issues that you've been dealing with. And sometimes people get worse. They can get the best care anywhere, yet sometimes patients do deteriorate. And if you're satisfied that we've done all we can and we still have a patient that deteriorates, guys, that can happen. All right. Okay, so he's calling in, okay, got her on a non-rebreather already, so that she's tripoding, so that's a pretty good sign that she's having difficulty breathing. He's reading the prescription off to the doctor, making sure it's her prescription, and he's getting permission to help her with her inhaler. All right, so make sure it's the patient's. Make sure you check the expiration date on it. A lot of times people have several of these scattered throughout their house, in their purse, in their pocket. So make sure that the one that you've got in your hand that you're fixing to help her with, make sure that it is within date. All right, and make sure that they're alert and able to use this device. All right, make sure you shake it up. All right, and then there's a little cap right here. That little cap needs to be removed. Have the patient exhale deeply, okay? Then you put this in the patient's mouth, have them place their lips around that opening, and press the inhaler and tell them to take a deep breath as you're pressing down on the canister. Tell them to hold their breath, and then, not for extended periods of time, but hold their breath, and then allow them to breathe. If they need another dose, if it says on there, give 1 to 2 puffs. Now, you're not going to see instant relief after the first puff, but if it says 1 to 2, then you can certainly do another puff, and then you can go ahead and put them back on their non-rebreather. All right, so make sure you reassess the patient after you give the medication, reassess all your vital signs, plan on the heart rate going up, because it probably will. When it goes up, the blood pressure is probably going to go up as well. The respiratory rate may actually come down, if it's increased. So just make sure you keep an eye on all their vital signs and see how they're improving, or if they're not improving. Now, this is the spacer I was talking about. So this just fits on top of this mouthpiece on the inhaler. They put their lips around this, and again, if they're not able to get the entire puff within one breath. It's kind of hanging out in here, and they should be able to get it on the next one. All right, now this is a nebulizer. This is most likely the same medication that is in the inhaler, except this is in a nebulized form. It's a mist that comes out of this little bowl that he's preparing right here. This does a lot of other things, in my opinion, that the inhalers don't do. Especially with your asthmatics, a big problem they have is their mucus plugs are so thick that they can't really cough them up. You want to dilute those some. Well, when you are having a mist down into their airway, like you have with this nebulizer, that's going to help loosen those secretions up. It's going to make it easier for them to cough up those secretions and help clear the airway like that. So this is you get this bowl right here, you get this corrugated tubing, you get this T-bar, you get this mouthpiece, and then you get the tubing that comes out of the bowl. You get all of this in one package. All right. So this is albuterol. You do carry this on your ambulance. So if you're riding with a paramedic, you basically are working under his license whenever you're working on an ambulance with him. So if he tells you to prepare an albuterol nebulizer, you're working under him, who he is working under a medical director. So you can go ahead and do this without you having to call in and ask permission. So you're going to put the entire bullet of albuterol in here. This has got 2.5 milligrams and 3 milliliters. You're going to put it in there. You're going to screw this on. You're going to hook the T-bar, the mouthpiece, the corrugated tubing. Typically 4 to 6 liters is what you're going to need to put your oxygen at. As long as you're getting a good mist coming out of both ends of this, and you have the oxygen setting where it needs to be. Now, let's say a guy has got asthma and you're giving it to him this way. I've never had asthma. I hope I never get asthma, but I got to think if you're having an asthma attack, you're not only going to want to breathe through your mouth, but you're going to want to breathe through your nose as well. All right. The problem with the way that this is given to this patient is the only way he's receiving the medication is through the mouth. All right. Also, this guy holding the nebulizer here, you see the mist coming out here? Well, he's getting a nebulized treatment as well. So if you're standing in proximity to this, you obviously can see that this mist is coming out. So, he can certainly get part of the medication as well. However, you can take this bowl and you can take the bag off of a non-rebreather and just plug that into where you pull that bag off. This guy's breathing through his mouth and through his nose both. We'll see that albuterol is filling that mask up, that nebulizer, I'm sorry, is filling that mask up with albuterol. So every time he takes a breath, whether it be his mouth, nose, or both, he's getting a pretty good dose of albuterol. You don't see any of the mist leaking around that mask out here like you do in this picture here. So not everyone in the back of the ambulance is getting an albuterol treatment like in this situation. This is my preferred way to do this. I think you get a lot better administration of the medication doing it this way than you do with the T-bar and the mouthpiece. All right. This will take about 10 minutes to go through, whichever one of these that you're using. It takes about 10 minutes for the medication to go through the nebulizer. You're going to see the same effects from a nebulizer as you would from the inhaler. Their heart rate's going to increase. They get jittery. They get nervous. So that, again, that's pretty much expected with the administration of this albuterol through a nebulizer. Listen to their breath sounds. You're hoping that that they're going to be able to move more air. You hope that if they had wheezes before, that the wheezes are either starting to diminish or they're completely gone because of the bronchodilation effects that this drug has. You notice he's listening on the back. Again, this is a lot better place to listen to breath sounds than on the interior portion of the patient. Okie dokie. So this concludes respiratory emergencies. Next up will be cardiovascular emergencies. Some of the things that you learned in this will kind of carry over to the cardiac stuff, especially when we get to congestive heart failure and pulmonary edema. So I hope you guys got a lot out of this. Okay, I hope that that you look at this like you're supposed to. If there's any, anything that I do talk fast, I understand that, but that's kind of the beauty of having this recorded. You can always go back and replay. Hit the same slide, replay it again, whatever. So I hope I did you a good job here, and I'm going to go ahead and finish this up. And then next time you hear from me, it will be cardiovascular. Thank you, guys.